Okay, in next 40 odd minutes, we'll try to go through and take some take-home messages, what we learned about with this extensive 12 abstracts or presentations that were made. So I've tried to put forward and concise it across categories. So, and I would be like to what I'll do is the data which is there versus the old data, and just correlate and what would be a take-home message and what can we do from tomorrow. Few of the drugs are not available, but once they get available, how it's going to change practice. First question, a very simple one, and that's where we start off with, because the point is, as we always used to say, all the EGFRs were same or not. We now know they are not. So Dr. Kumar, I'll just very quick and I'll start with you. Are all immune checkpoint inhibitors the same? When we started off maybe 5, 7, 8 years back, and all of us use these data interchangeably depending upon which is cheaper to the patient. So point number one, are they same? And should we be interchanging immunotherapy drugs, or should we be very specific to the approvals, what they are for on the data set?
So I also, what you said is right. I also used to think the same thing around maybe a few years back. But more the recent data comes, more I'm concerned. Why in kidney cancer, 3 trials are negative, 1 positive. Bladder cancer, 2 trials in adjuvant, 2 trials in metastatic setting negative, 1 positive. Many lung trial which are negative, which doesn't come to us. If you go back and start reading, realize many of the negatives we don't realize it. It has been talked to us. Then you start getting concerned. Then you say, no, what you get in trial, be careful. Don't modify it. Learn a bit more. The way we learned cisplatin, and then start changing, in future. So at this moment, good to go by the way the data is.
Okay. Any difference of opinion? Okay. So the house feels the same. And how many of you have interchanged a protocol of immunotherapy just because you're available cheaper? No one? Good. So I didn't need this question. Yeah. So you did that. Only the only honest person.
Sir, one patient. So I had a patient of MSI has squamous carcinoma of ureter.
That's
so
okay.
Atezolizumab was the cheaper, so I have given that.
So I don't want to go to individual cases, but my time is short. But the point which I wanted to make with this,
can I interject?
Yeah, please.
So now Samir gave a very good example where you can interchange. So I think this is the way science is, that you start seeing consistency of data in certain situation, and then you say, okay, isme to.
That patient is in CR last 2 years.
If it is the second line lung NSCLC, you can actually say Nivo, Atezo, whatever is cheaper we will get. If it is PDL1 more than 50%, you can think about Atezo or Pembro, whatever it is. What I will not do is give Atezo, Pemetrexed, carboplatin.
Can I interject?
Yes.
So in second line, Nivo and you said Atezo, Durvalumab?
No, I will not give.
So I was coming to that situation.
No, I will not give. So I will give only per person per approval of the drug.
So yes. So what is
I
coming?
think, sir, if all ICI are same, then why the indications are different and they are not working in all the cancers? If this is like all the platinums like that, we cannot use all the platinums in the same indication.
Okay, so I'll make this brief and I'll just go ahead with this. The point that I wanted to make with the first question is, look into the data sets. If the data sets have the approvals in a particular setting, then you probably might go for a cheaper one which is available to the patient, or as per the toxicity profile of the patient, what you want to choose. But just don't interchange. And I'll come to one of these example why we should not. Just because the drug is the immunotherapy and it's available cheaper, they work very, very differently, and gradually as the publications are coming in, you would find this much more that some of the drugs are positive, some are not. So that's point number one made. So people do agree. Now we jump to the real things and let's see what we do. So we have 50 years old male, non-smoker, presented with advanced non-small cell lung cancer, and it was non-squamous, no brain metastasis. Liver has shown multiple metastasis with multiple lung and bone deposits. I hope this makes the case of the load of the disease being very high. The PS is 1 bordering 2, no targetable mutations, and the PDL1 is 55. So there was one such decision which we spoke about, the data for Pembro and the IO combination with Pembro. I think so that it was keynote 598 which was spoken here. and that is the data for versus pembro single agent. So that data was presented. So in that subset of beyond 50% of PDL1, now I come down to Nandini first, just quickly, and why we'll come to different. Best supportive care alone, immune checkpoint single agent, if yes, which one? Platinum doublet, immune checkpoint plus chemotherapy, or would you take the last trials which was that TGIT inhibitors with immunotherapy? This does fit in with this. What do you think it is? Or a IO-IO combination? Yeah, you can take one of these. Yeah.
Sir, so considering the disease volume, sir, even though the PS is 1, bordering to 2, I would be tempted to go with immune checkpoint with some additional agent, in our setting mostly chemotherapy.
So you'd go for IO plus chemotherapy. The 189 data is what you would follow. Anyone for immunotherapy alone? And if anyone different?
So I would see on which platform the NGS has been done. This is a never smoker, and the chance of having a target mutation is higher. So if I'm not convinced with the...
So it's convinced. Let's
NGS,
not go into and start questioning the labs. It is done.
Never smoker, so that's the reason why I raised the
So
point.
is it, are you telling that if it's a never smoker, it has to be definitely positive for a targetable mutation?
So not necessary, but I will...
So we confirmed it and it was not showing any mutations.
Okay, IO mono, I'll go.
You would go for a IO monotherapy. Okay.
In our practice, maximum patients are PS2 only. 80% patients come with PS2, not the PS1 is not there
So
in,
this-
in real world practice. And patients are having higher disease burden with liver mets and etc. And immunotherapy alone takes the time to act if it is acting. Because it is not the 100% that if the PDL1 is more than 50%, then immunotherapy will work only. So I will take the chemotherapy along with the immunotherapy in this sense.
So does chemotherapy and immunotherapy work 100% in a patients?
Chances are high and this will work rapidly.
We'll come down to that. When you told chances are high, I'll come down to that. Comparing IO plus chemo versus IO, and let's see what the data is. We don't have a direct comparison, but there is quite a data set of exploratory analysis, and we'll come to that. Chandra, you told of single agent. Which one would you choose here?
Pembro.
Pembro. Atizo.
I mean...
You can choose anyone actually.
Atizo plus...
Would you choose nivolumab?
TGIT, all of that.
Would you choose nivolumab?
Nivo EP.
Nivo EP.
Nivo EP, 9LA,
Okay.
all can be used.
Okay. Does Nivo EP score superior to chemotherapy? That's a data well set done. Does it score better than a single agent immunotherapy? Do you have any data set for that?
So Nivo EP versus chemo.
No. Nivo EP versus IO. If you look at Checkmate 227, it was a Nivo EP, a single agent immuno, Nivo, versus a chemotherapy. In the PDL1, high. So in that group, the data set which we normally speak of IO-IO is the IO-IO versus chemotherapy. That IO versus IO-IO is not there for a statistical review. It was numerically higher, but the statistics was not there. And if you look at the Pembro and the data, the Checkmate 598 put, it was actually a negative trial. It did show that the addition of a IO-IO to single agent IO in this high subset did not benefit.
If you look into Nivo EP, there was in more than 50% there was versus chemo, not versus IO.
My question is very different. Dr. Kumar, I'll come down to you before I come to the audience. So now we have a question in hand that we have approvals for IO-IO in this subgroup. We have approvals for IO chemo. We have approvals for IO single agent. So these are the three things which we look into. And also I'd like to have your outlook on the TGIT inhibitor and the pembrolizumab data for more than 50%. Because if you look at the data, the OS hazard is 0.3, never heard of, for TGIT inhibitor and this. The first time we are seeing a OS hazards to be 0.3. So what do you take of this and which is your drug of choice? If you go for a single agent immuno, what would you go for?
So first, what we choose, one of the aspect which is usually taught that if you have a PS2 patient, why it is PS2, and it looks like a whole lot of because of disease here, and that's why the patient is PS2. So second issue is that we want faster treatment to work, that as early and as much it works, both, because you want more percentage of patient responding and early it works. What we know that if you combine chemotherapy plus IO, then more patient responds and alone IO, there is an issue regarding, I didn't say faster response, don't get me wrong, because the problem is that in all the responses, the response is evaluated at 6 weeks.
Time to response is
Time
what
to
is-
response, so it will be always around 2 months for you. Because no one has done responses in between, and that's a challenge because that's the way the trials are designed. But if you see percentage of people responding, then it is far more if it is IO plus chemotherapy. So that becomes second, which comes to my mind that that's the way I'll be choosing the treatment in this setting. Having said that, I do agree all options are open. Not only that, data came in ESMO for atezolizumab as a single agent for PS2, 3, 4. Remember, 2 was there. 2 was not missing in that, 2 was there. And that is where, I always question that 2 where to put in, depending upon trial people put
so
in.
for this discussion, we'll come to PS1 only. In this case, I want to make it PS1.
PS1.
Yeah.
So then, if we want a faster response, we want more patient to respond than IO plus chemotherapy if the patient can take it. And we do have 2 options in those settings. One is your option, what we talk about, only one IO and add chemo. Otherwise, you have 9LA. Then you can have both of them and give for short period. You have respond, you think my IO is working very well.
So I'll ask you a very straight question, and then at Ullas, you can come in if you want to. Where do you put IO in this subset? Is this that it does not feature in your schema of things, and you do not consider IO to be a frontline or go-to option?
So I have in my mind, I'll tell you where I think it is useful. Hardly ever I've used it, maybe because many of my residents here, so they know it. If I lie anything, they will come up and put their hands up and say, कि ये तो बोल रहे हो, लेकिन ऐसा होता है नहीं. So hardly ever we use it, primarily because of the cost. So if you have 2 situations, if the PD-L1 is negative,
No, let's do this situation.
this one,
More than 50%.
more than 50%.
No, it's coming to your face.
Only
I can read your face. Ullas, IO, very specific question to you. Do you think you have a patient profile which fits into IO?
That depends upon what the BMS is listening on.
No. They can listen. That's okay.
Then there is no role.
Okay. And
More than 50%.
Brain mets?
Sir, so I'll tell you where do I, as you said, PD-L1 negative, squamous cell, brain mets.
That's
and
okay.
That
That's
is where
okay.
I would actually prefer to use.
Okay.
In PD-L1 more than 50% because of toxicity, I may not use. That is the only thing. I would probably use Pembro or a Pembro plus.
Nandini, coming to you, the point is coming for you also told is IO plus chemo. So where would you like to use the IO single agent, let's say Pembro or Atezo? For one of these 2, where would you use in this subset? Which patient profile would you like to use the single agent IO? Because 2 or 3 out of 2 are coming towards chemo plus IO. That's because you want more quicker response, more patient to respond, the bulk is more, so you want to do that. Which patient would you tell the house that this would be ideal patient for a single IO?
So in a PS01 patient with PD-L1 more than 50% with the lower disease burden, like
Okay.
no liver mets or lung mets, no dyspnea at presentation.
Okay.
In that, I would prefer to use a single agent rituximab, and based on the Ipsos data for PS2. older
We'll leave the
patient-
Ipsos is now catching very big grounds. I think I will talk about Ipsos a little later. So that's profile which you think. Okay, anyone in this house has used nivolumab for single agent for patient beyond 50%? Be honest, because it is cheaper. It was cheaper. Perfect. So the one more honest person coming out. Hey, I'll come down to यार उल्लास moderate मैं कर रहा हूँ. नहीं मेरा point है कि is just Kumar boss has used it, no one else, because it is cheaper any day. Yeah, और एक हाथ उठा.
In PS2.
PS2. So, okay, whatever. Very good. So I'll come down to this. So what factors should be considered choosing single agent? It very, very clear. I'll come down to next slide. But things that's come into what Nandini told, I'll just add one more. And if you look at the data set and which one presentation was there, if there's a smoker and if there is a single agent IO can really come in, the chances of getting a response is superior. You have a more indolent disease and the score is more than 50%. There probably you look at a single agent IO, but if you want to get a more like, because the progressions are much higher, 35% around is the PD. which is taken care of when you use a 189 type of protocol. So that is the factor, I think, except what Nandini told. I'll just add a smoker, gives you a lot more confidence with this factor that a single agent IO would be good enough. Coming to why I did pick that nivolumab is I know people may not raise hands. A lot of people use it. When they come to 50%, especially the drug cost is the issue. The IO chemotherapy, all we have put across. I'll just come down to this part of it. Chandrakant, can you tell me more than how has been experience for PDL1 more than 90%?
Pembro mono, sir. No, I've used Pembro mono. They have responded really well.
Okay, so these factors do not matter then.
Which factors, sir?
What Nandini told. Truth there.
Sir, so more than 90, sir, I use Pembro mono. I think that is upset where you are. सर पैसा नहीं है तो कैसे देंगे? Nivo 40 भी देंगे सर.
Sorry, this is the best thing of having a non-pharma sponsored panel. You can be clear. Okay, now I am got a more serious question. 90% people told excellent. So what I'm going to tell you is this data of Ciplumab, and if you look at this data and look at the last line which is there, the blue dot which goes in the lower part of it, and look at the PDL more than 90% on the table, you would not find such beautiful PFS. I'm going to PFS. OS is definitely expected. Look at the PFS of this group of patients, 15.3 months, compared to what you would never see. And look at the hazards for the PFS is 0.28. So here what gives you confidence that the higher it is, the better, and more touching the 90% mark. The data for PFS is also very strong. It's a published data from a phase 3 data again. All of us know this. So this is something I wanted to make sure that we also look at the values of the PDL1. So this I will just go through, and the nivolumab question was asked to Dr. Kumar, and few of us raised hand, most of us did not. And I know that you will be feeling guilty now. This is the data set which comes into, and this is, look at the last part of PDL1 more than 50. There was, and this OS and PFS is exactly dot on the same for the Nivo. And this is keynote, this is the checkmate 028. And if you look at the PDL1 more than 50%, which you expected it to be should have done very well for this patient, because this was inclusion of more than 5%. So they subdivided it. And these numbers were not that low also. It was 88 number of patients. It again did not show significance. So point is, if you look into the literature, nothing is conclusive. This is one data set which is going against. So that's point to make that all immune checkpoints are not similar. Look at keynote 024, which is a positive 026, not 8, sorry, which is a negative checkmate. They looked at the selection differently. The tissue blocks in the keynote were new tissue blocks. Here they're more of archival, but there is again a controversy that. But most important, what they felt was the use of radiotherapy, which was different, and never smokers. There were 97% of the keynote 024 were smokers, while 11% were not. And TAT that was allowed for keynote 024 was 1 month. That could be the thing, that indolence was the issue that they really took care. Okay, we'll move on. But this I made on my own. So what I felt was 30% patients of PDL1 more than 50%, 35 are not eligible for systemic therapy for any reasons before the Ipsos came into picture. Okay, so now 15 to 35% is EGFR ALK positive, 10% needs steroids or immunosuppressants. So effectively 10% only eligible for single agent immunocheckpoints. So I'll just skip this. Now we come down to this part which people told. Dr. Kumar, I'd like to know your comment on this, or anyone in the house. This is the data set across trials comparison again, which looked into monotherapy versus combination. If you look into the 3 years OS is nearly the same, around 40%. The toxicity is higher, nearly double for the 189. So exactly if you look at it, so there should be a selection of patients for 189. Do you agree strongly to that? Not every patient should be receiving a chemo and the immune checkpoint?
So I agree with you that there is no point throwing everything in the sink at the same moment, because what drives long term is your immunotherapy. But there are group of patients where you require good responses.
The early responses.
Early responses, good responses, and there where you start choosing. Like if you, for example, if you have a 2 centimeter lesion here, and 2 here, now that may become oligometastatic disease and we can have a separate debate for it, but you want to treat with a systemic therapy with PD-L1 of 80%, why not? You can choose as a single agent.
So this part of the thing is that smoking and bulk of disease is the most important criteria to choose between them. The PERSE and the INSIGNA trials will really give us the idea of, in this subgroup of patient, there will be 2 randomized trials that will be coming up in next 1 to 2 years. This will give a real picture of whether we should go for IO and the chemotherapy or IO single agent. Okay. I'll just skip this part because we are locked into this. Just can anyone in the panel take this? No, anyone? Why IO plus IO? Any benefits of a IO-IO combination? Does anyone feel that IO-IO combination is there even in the select group of 1 to 49, let's say, or more than 1%? Brain mets, comma cell, we leave that 2 parts apart. Last. Okay, I'll just be little bit, there's some data on the post-progression, you can use doublets of chemotherapy in IO-IO or the LA9A, the short course chemotherapy. Otherwise, chemo-free regimens for compromised patient could be one condition where it is. Okay, we'll switch gears. Dr. Tarachan, if you have a KRAS mutation and do you think, let's say, a G12C or a non-G12C, does it make a difference? For question number 1. Question number 2, do you change your treatment for a patient who just have a KRAS and has a PDL of 10%? How do you treat these patients?
Yeah, because of only the KRAS, usually I don't change the treatment.
Okay.
But I go with if the PDL1 is positive only 10%, then I am using the IO plus CT only.
Okay, if it's more than 50%?
Then the Nandini criteria fit, then IO alone.
Nandini criteria. Okay. So any difference in opinions? No. Yeah, you wanted to say something.
I think for KRAS,
Mhm.
we need to now understand KRAS doesn't come alone. KRAS comes a package. So only KRAS mutant, you have to also look at the STK and the KEAP. What I would like to tell, and I think there was some, I think only 16% of trials had reported KRAS status. They had not reported STK and KEAP.
Okay.
So, on the small coupon panel that we have 12 gene, it does not include the STK key.
Okay.
So KRAS, whenever you are evaluating for 12C, look at the STK key also and then take a decision.
So what is the decision you'll take?
So that's why I was saying triple mutant have got the worst kind of a thing. And if you have KRAS wild type and things, then I will give ICI plus.
So you will still do that, but prognosis will change.
And the Posiodon data which was presented, we said the best data was about STK and KEAP mutant was with Durva Tremi plus chemotherapy. That data is going to come in another 1 more year, but the ASCO 22 said if you have a STK KEAP mutant, give the IO plus two the chemo combination.
Plus the chemo combination.
So the best, maybe the new option of double IO plus chemo will come for this STK KEAP thing on. But
Okay.
we first test for it.
So if you have a KRAS alone, don't change anything. If you have all the 3 also, don't change anything at this point of now.
Test for STK KEAP.
Huh. So if you are doing it and you have all the 3,
See, right now you give immunochemo.
so that's it. The prognosis will change. Probably the IO plus chemotherapy becomes a... Okay. Okay. So as of now, the basically what I want to make out, and this is the data set from 042, and again for the high PDL ones, and it does tell you that the PFS is better for the KRAS non-G12C or with G12C versus the chemotherapy arm alone. So you don't change anything on the KRAS for this targetable mutation. What Ullas is telling you that there are much more prognostic markers which are there with the KRAS which might make us change, but as of now there is nothing for you to change, and do not hesitate to use a standard drug of choice at this point. One more data set which really comes in is the KRAS inhibitor and immune checkpoint. Anyone would like to go for the Crystal 7 trial? Anyone, any data, Dr. Kumar? Anything?
Not no, at this moment. At this moment,
Frontline, would you give a chemo-free regimen? That's the question I want to ask. Just go for a KRAS inhibitor and go for a pembrolizumab.
it may come in
Okay.
future. If your DCR is 100%, and we are seeing this kind of responses in other tumor also, taking bladder as an example, enfortumab plus pembro, that response is 80%. We have not seen in the past. So looks like this gives you a hint what is going to come.
I just wanted to find out, like, what my perception was, the KRAS C, that would be more sensitive disease pattern rather than the other one. Yeah. So the STK, isn't it in the other subset? That's what I look at.
You can have concurrent mutations of KRAS C and STK
Yeah. So what you told is there in this. If you look at the KRAS, the middle table, it shows this is the high best benefit. The non G12C has the second best thing, and the chemotherapy alone is the worst. So what last is telling is possible that could be there. Smoking I'm going to change, but this trial I would like to have one comment and then move on. Look at this upper one, for the PDL1 more than 50%. Look at this data set. And this is something which I feel if in our phase 3 trial it is there, will come as a go-to protocol for the affordable class for more than this, because the PFS is superior, never seen before. The OS is superior, and this is the data is the best which you could find till now, but it has to be replicated as is told. But I think this is one of the page we should be looking ahead in the future. Okay, we just switch gears for the most sought after, the PS2-3. 85 years old male, smoker, advanced non-small cell, PDL1 unknown. I'll come quickly to the question. Chandrakant, will you do a pembrolizumab single agent or atezo single agent for patient for PS2 and beyond who are PDL1 negative?
Yes.
Yes. So because of this data, and you are convinced of this data.
So PS2 means, PS2 is a
PS3, let's make it more easy.
Yeah, so PS3, yes.
Okay, PS3, you would do it in PDL1 negative also. Nandini, PDL1 0. PS2, 0. PDL1.
Explain that they may not benefit. 85 years and above.
70 years? As per Vanita, elderly 60. You only told us that EMS told us elderly 60 in India. So now 65 years. So my point is very brief. Should you be doing a pembrolizumab single agent for a negative PDL1? Is a very specific question I'm going to ask in this subset. Kumar boss.
You said any TKI or pembrolizumab?
Pembrolizumab
Oh,
or atezolizumab for a negative PDL1.
Patient. So, as a usual reflex, it is no. Have I given it? Yes. This was the first patient, and nivolumab, I'll tell you the story. It was the first patient ever I gave immunotherapy, and Vijay is here and he knows the story, and this was a relative of one of my colleague, and PS3. We had counsel all best supportive care done by more than one of us. And the family all of them were doctors. A wife had a breast cancer. So they said, are you sure it will never work? I said, that we don't know. I said, why don't you try? I said, okay. So we gave nivolumab.
It was negative for PDL1.
It was negative for PDL1. Patient survived 4 years. A wife died in between.
So we did it with which platform?
SP263. So does it mean I want to? Do I mean to give a message that every patient tomorrow you give it? No, that's not what I'm giving the message. But sorry.
No, please go on.
So, not I'm saying every patient tomorrow you will give the immunotherapy to PS3 and PS4 with PDL1 being negative. But you will encounter a patient who will ask you. I had a bladder patient, and where the experience was the other way around. And this was not from Mumbai. That was from.
So what will you tell the house at the end of the day? Leave
don't
that one
say
patient.
no. Never say. See, you are in medicine. Medicine, this is what we are taught from MBBS. Never say no, because you can't say that. You have a situation. But do I say to everyone to take it? That will be wrong teaching from my side.
So how do you select that in PDL1 negative? Which patient to do it?
So there are this is demanded by patient. In the surgery, they say the patient earns the surgery. Here, the patient earns the immunotherapy.
Dr. Ullas, are you convinced of the Ipsos?
No.
Why? Because this is the only data set. We look at the Pembro, it was the PDL1 more than 50% were a good 60-70%, and 1% was around 80%. But this, the most striking for me was this of negative PDL1 50%. And still this was a positive trial.
Sir, we have published data from our data collated across India that PS2 and above immunotherapy doesn't work. Number one, a single agent immunotherapy doesn't work in patients with more than PS2. We
I
have
think there's one data set from TMH just published which says it works.
We have a collated data over there. Yeah. So the second is PDL1 negative. We have umpteen number of data which says immunotherapy single agent doesn't work in PDL1 less than 1%. So I will take this with the loads of salt.
So you will still need
I will.
further data, read the full text.
Yes.
Akhil, convinced? First question, does immunotherapy work in elderly? Yes, no.
Elderly is a different story. Yes.
PS2, 3.
PS3, that we need to select patient, we need to decide the patient expectation, family expectation, that will drive the decision.
That expectation apart, scientific expectation.
From the science point of view, yes, it works in some patients. We don't know which patient works.
Negative
but
PDL1, will you do
yeah,
it?
We can do, but it will be a small. We know that the quantum of benefit will be much smaller.
Okay, the point which I want to make is there is a data for you to back up now. That's the only thing, but I don't think it is convincing at this point. And the PDL1 negative is something that really pulls me back. I myself would like to wait for the full text to read through, or I like 1-2 more data set to be there. Until if it is one way direction, probably there's something we're missing. The testing could have been much better. That's how I'll take it.
Can I add?
Last, I'll take this because
Can I add here?
boss, iske baad.
Oh.
Please, because they are pushing me out. I'll take this last one and then I'll come down to this one because this is something which needs discussion. Extensive small cell lung cancer. We saw that article. I just want to ask the panel, what did you think of the Astrum 005, the serplulimab and the chemotherapy which was shown in comparison to the Caspian and IMpower? If this drug is available, would you do it? If you look at the OS, it is numerically superior. The two trials, Caspian IM133 was 13 months and 12.3, dot on the same. Here it is 15.38 months. The hazards for the OS is again superior, again in comparison to 0.7, and here it is 0.58. And even the PFS is something that is good enough, and the PFS is also superior for this, the Astrum. So, yeah.
It's a complete different population, but so that might be the reason. For
So
that.
because of the population, and if you replicate it in one more trial, it will be much more convincing to you.
Yeah, different ethnicity.
Okay.
Because we see
ethnicity,
that
China thing
and
is
Japan do differently well in
okay.
every
So
trial.
that is your only concern about this study.
Yes.
Because if I look at the Astrum 05, one more thing strikes out. They allowed stable brain mets. Around 10%, 15% of this Astrum 005 were stable brain mets. Untreated brain mets who did not progress for 2 months on radiology were also allowed to participate, which has been a main talking point for Caspian till now. So this has been also addressed for this Astrum 005.
I think what he said was right, I mean, in the NAG chemo plus target therapy arm versus the KN regimen, I mean, there were 52 months. So I think there is a difference.
Okay, so the ethnicity is the concern. So otherwise, if you keep apart the ethnicity, the trial looks good enough as one more option.
Yes, yes, yes.
Dr. Kumar, your final thoughts on this?
This reassures us. These kind of data reassures that what we are doing is right, and if you are using these treatment in the clinic, it is giving us similar.
And if anyone looks into these three curves and one go, you will see this trial again to be looking superior. Yes, the Chinese and Japanese data concern is taken care of, and no need of adding an IO for this combination for small cell. That data is very clear. So I will just go to the last part and then come down to the PS2. Advanced pulmonary sarcoid carcinoma. Tarachan, have you treated any case in the last 2 years? And if yes, by what protocol for
Not in
advanced?
last 4 years. I have not treated last 4 years.
4 years also.
Yes, I am doing NGS for all the patients now, if they either pulmonary or any patients, to find out any targetable mutation I can find.
Okay.
Recently, I found a RAT mutation in GBM patient.
Nandini, NGS for all, look at mutations for sarcomatoid, or do you give a platinum doublet for sarcomatoid, first line, and then look for a target?
So we give platinum doublet, will we also consider doing an NGS if the patient is...
And if the NGS comes positive, you wait for the platinum to fail and then give the...
No, we would, considering the aggressive nature, change to the targeted drug if the evidence...
Dr. Kumar, if you have an NGS report on your table with a sarcomatoid variety, very bad, chemotherapy really doesn't work. All of us know that. Would you go and target the therapy that first, or would you go for chemo failure and then go for it?
target. CMET is fairly common. First report came for 50%. It is now far lesser. We thought 50%. We did some NGS and we realized not so common. But if you have it, target.
Okay.
But I think so. I think so. You want to bring out sarcomatoid variety across the place where you want, your kidney or wherever. Looks like immunocombination does something strikingly different, and that's what I think so you want to bring out. And I agree with that. Yeah.
So this, Ullas, your experience, NGS, and if there's a target, go for it. Plus immuno. No. Okay. Then immuno plus this. Okay. So I think.
This is the situation where we'll use even altered doses, surely. Altered doses of immunotherapy. Altered doses.
Altered dose. Ultra, tum to yaar. Okay, the last 1 minute I'll give. Samir, you wanted to say something, and then Dr. Kumar about that. PS2.
Regarding immunotherapy, so whenever option is either therapy versus best supportive care, so in that case, I always counsel my patient, it's like taking a lottery, buying a lottery. You invest money. If you are lucky enough, your immunotherapy will work like a lottery. So if the patient can do for years and years.
The point is.
The
point is
is gone.
no. The point is, if someone has not done a PDL1 or is a PS3, then don't do a PDL1. Be happy and just treat it for all comers. Dr. Kumar, your last word on this, because I think lot of this house is going back tomorrow and going to start giving immunotherapy for all PS3 patients tomorrow. Ek minute. Science first, because this is a very important message that should go, because a lot of patients are PS2, 3, 4. So should people be practicing and offering single immunotherapy to these patients, and how should we select? Last 1 minute or is all yours.
So first is that PS3P, we have a good number. That is very true. Not necessarily in private setup, but definitely in academic setup, whomever we have talked, almost 30%. That's our number. So there is a merit to having this discussion where we did some work on it.
In negative PDL1 specific.
Coming to negative PDL1, so that's a complicated one. So now what happens is definitely we should not club them all together, because of you will have mutation positive patients where you can use it. Chemotherapy is a viable option. Don't forget that. Gautam is not here. Gautam took a series of patients for last 3 months. Now he left and went to Nagpur, and then the kids, they don't listen when they're out of the house, so he doesn't listen to me now. He was supposed to analyze the data and tell us how many benefited, and he kept it serially. All patients of PS3, 4. You do get patients who are only because of a disease where it becomes bad. Give them chemotherapy. There is a value in it. Coming to
even this data, to break you, even the data for chemotherapy OS is 9 versus 10.
Yeah.
And look at the OS data for this best supportive care. It is 2 months versus this. So there's a difference. Chemotherapy works. That's well.
So there, again, it was here the patients were chosen who were fit for chemotherapy. Remember, there is a catch there. I am the third author in this paper when it will be coming soon, and where it was presented, and we contributed good number of patients. It is the take-home message is not these are all PS3, 4 patients. Good number is PS2. Good number means a very good number is PS2. Second, they have a lot of caveats regarding a lot of comorbidities, where there is an issue regarding those are not typical PS3 all-comer, which is bedridden. So there is a need to be carefully interpreting this data. So what Dr. Sahoo wants to be conveyed tomorrow, not every PS3 patient, 4 patient has to be given immunotherapy. No, that's not the take-home message. I'm aware of this, the patient recruited. There were not those patients. But do I convey never do it? No, I insist that. Never say never in medicine is important. And that is the way you will learn. What happens is, out of 10 patients you treat 4 benefits. Here, out of 10 patients you treat 1 benefits. Now, is that ratio good enough or not? When I tell my patient, out of 10 patients you treat, 1 will benefit, and out of 10 patients you treat, 2 will have a toxicity. Majority, they don't choose the treatment. But do I get some patients who choose the treatment?
Yes.
They do. But that we need to remember.
Okay. So to end the moderation, thank you, the panels first, the audience. I'll just add last thing for this hotted thing. I think PS3, 4 are a different subset, should be taken very, very seriously. PDL1 negative, my point is the progressors will come back to bite you. So be very, very clear for single agent immunotherapy. Don't forget the amount of progression. And that is never, and PDL1 negative, the progressions are much more higher again. So that is something that will bite you. That data set is not there for that subsets. But at the end of the day, what I felt was it is exciting time to be a medical oncologist treating lung cancer, at least in this decade. Second, options are expanding. That we got with the TIGIT. For me, that was a very good data set which I look at the phase 3 data as it comes into, and survivals are definitely increasing. We've never seen lung cancer surviving 3, 4, 5 years, and this is something very good, and toxicities are coming down. That's what every trial is coming to. You want to say something, and I leave the stage. See, they included low PS patient or patients who could not take a classical doublet. That was a point to be well mentioned, that there are patients in our practice who are not eligible for that. So I think the profile is very different. That is
But usually what, if I want to give a single, I want to prefer a carboplatin over and above gemcitabine. Like
So this trial is not eligible for that. That was a comparison. This data set, I'm very clear, we'll finish it here because others have to go on. The best supportive care is the arm.
Gautam will share the data with you.
And the second arm is those who are eligible only for a single agent because of the PS or the age. So very, very clear on that part. I think that was what the trial wants to communicate. In this group, best supportive care was an option, or single agent chemotherapy was an option. Now we have immune checkpoint coming in 2 different trials showing to be super result. But how do you take it with a pinch of salt is your day. Thank you. Thank you.